Thanks. Okay, good morning, everybody. Thank you for joining the September Long-Term Care Planning Committee meeting. This meeting is being recorded, so we do ask that you keep yourself muted unless you're talking. And when you do speak, it would be very helpful if you just also state your name, especially if you're on the phone, so that we know who you are. The recording of the meeting will be posted within 48 hours on the Long-Term Care Planning Committee website if anybody wishes to go back and rewatch any part of the presentations that we're going to have today. So Heather, before I officially kick the meeting off, I'm calling it to order at 10:02. Would you mind calling the roll?
I'd be happy to. So Melissa Morton.
Here.
Amy Dumont. William Seals.
Here.
Margie Girondo Marquette.
Here.
Kelly Kendall.
Here.
Well,
Aaron Levitt Smith.
In the event.
Here.
Kim Hirschniak. Amy Porter. Jessica Rival.
Here.
Lisa Rivers.
Yeah, so she's technically on paper.
Michael Santoro.
So
Here.
she could apply
And Laura Watson.
She receiving home care or is she?
Right. Thanks, Melissa.
So today is one of our favorite days of the year here at the Long-Term Care Planning Committee. It's the month of September, which is when we do DSS joins us, the team from the Community Options Unit, to do its annual long-term care rebalancing update on all the initiatives they have going on. And Bill Halsey, who has been wearing many hats over in the Medicaid division the past several months, was good enough to work with his team and continue the tradition of providing the rebalancing update at this year's meeting. So that'll be coming a little bit later. And then also, I'm pleased to announce that Mairead Painter, the State Long-Term Care Ombudsman, agreed to join us today as well to give a brief update on the status of the new community ombudsman and to introduce our new community ombudsman to the group. I thought that since we now officially have that role on board, that members would like to meet our new community ombudsman and hear a little bit about how the program is going and getting off the ground. So with that, Mairead, do you have the presentation to pull up? Would you like? Okay, great. I'm going to turn it over to you.
Great. So we will share our screen, I think. So for those of you who don't know, we have a new community ombudsman manager. The new community ombudsman manager is Daniel Beam, and Dan is on today. Dan, you can say a quick hi.
Hello. Nice to see everybody.
Yay, Dan Beam. Last session, we also received one position for our regional community ombudsman, who we will be hiring, who will be working with Dan. And we're just starting to sort of tease out the parameters of the community ombudsman program. As we start to work on this and put parameters in place, then we'll be reaching out to stakeholders as we put policies and procedures in place and move forward. So this is the introduction. Go ahead, Dan. Go over just a general overview and our goal, functions of the program. Dan, you go ahead. This is your program.
Oh, sounds good.
Okay.
Yeah, and so the Community Ombudsman Program, again, the purpose of it is to enhance the quality of life and the care for Connecticut citizens who receive their long-term services and supports. The settings that we'll be covering will be residential care homes, assisted living communities, and private residences or private homes. The work of the long-term care ombudsman program in the community will be similar to that of the long-term care facilities in that it's all person-centered and private and confidential. So the actions of the ombudsman will be at the direction of the individual that is receiving the long-term services and supports and will remain 100% private and confidential unless the individual would ask us to follow up in any particular way. So as of right now, I'm the community ombudsman manager, and as Maria had mentioned, we are moving forward with hiring our first community ombudsman. Very excited about that. And in the coming weeks, we hopefully will have one hired. Responsibilities of the ombudsman include responding to complaints, investigating complaints from individuals, families. Any individual can report a concern based on a concern about an individual receiving long-term services and supports. But as mentioned before, we only follow up at the direction of the resident and or legal representative if the individual is not able to make their needs known. We also provide information and consultation to individuals and providers related to residents or individuals' rights, as well as services that they can be offered through the Connecticut Home Care Program for Elders or other various Connecticut waivers. We monitor state and federal laws, regulations, and make recommendations for improvement based on any gaps of services that may exist. And so ways that we support individuals in the community. We assist in resolving problems based on individual complaints that come in, educate about rights for individuals and families, empower residents. We support discussing concerns with care and service providers and encourage them to self-advocate themselves. And again, providing information and resources on long-term services and supports that exist here within the state of Connecticut. As far as as mentioned before, talking about the improvements that can be made, identifying gaps in services. As far as representation, again, the resident themselves or individual themselves is our client, and so we follow up based on them. And as mentioned previously, privacy is of the utmost importance and confidentiality within our program. A general summary of some of the rights that individuals may receive or have. For example, this is for individuals that reside in a residential care home or assisted living facility to make their own decisions, to be treated with respect and dignity, to manage their own finances or to receive help in doing so, to voice grievances without the fear of retaliation or reprisal, to associate and communicate with individuals privately, to send and receive personal mail, to have their medical and personal records kept confidential. Financial assistance to apply for state and federal financial assistance, to be fully informed of their rights and to be fully informed of their responsibilities, conditions, services, and charges which may apply to them. And as far as residential care homes, the right to receive advance notice and the appeal rights for any transfer or discharge that would be issued to them.
Dan, hold on, right, go back to that one for 1 second. And this
Okay.
is where I can see we'd want some input from our stakeholders, but this is where I see individuals in the community being able to really build that out, where this is for people who do live in the community, rights that we want to see protected as well. People being fully informed of their condition, having access to their mail, privacy, talking to people of their choosing and ensuring that they have access to all of those things, even if there is someone who is supporting them in the community, helping to maintain them in the community. These are the issues that we hear come up when we are receiving calls, because we're already receiving phone calls from people in the community where sometimes they have someone who is controlling their life a little bit and they're saying, well, I have to do this or I can't do that, and offering them support in those ways. So for further building that out for them and explaining to them what that means and what their rights are. And this is the biggest area that I see how we are different from protective services, because that's one of the main questions we get is how is this different from protective services? It's that we are not mandated reporters. We really represent the individual themselves and supporting them in these rights. All right, go ahead, Dan.
And again, for any individual that's in the community that needs assistance regarding their rights, care, or services, they can reach out to our program. I've included the QR code here with the slides, as well as our contact information for our main intake line and our email address. Any questions? Great. Well, with that said, look forward to working with all of you guys in the future. For those that I haven't met yet, nice to meet you. For those I've met before, good to see you. And yeah, feel free to reach out with any questions or concerns ongoing. Thank you.
Thanks, Dan.
Thanks so much, Marie and Dan. Dan, great job. So glad to have you on board. That was a great overview, and I'm sure we'll keep the dialogue ongoing and perhaps have you guys back periodically, to talk through how the stakeholders on this group can be helpful. And if there are any issues that you're seeing in the community that you would like to bring to the long-term care planning community, or ways we can all better work together across the long-term services and support system to support folks in the community. So thanks for your good work, Marie and Dan, and for taking the time to join us today. I appreciate it.
Thank you.
So with that, I am now going to turn it over to the Department of Social Services for their annual long-term services and supports rebalancing update. At this point, I'm going to turn things over to Bill Halsey to introduce himself and his team and kick us off.
Good morning, everyone. Thanks, Melissa. We have a lot of DSS folks here. I'm going to introduce Lauren and Carrie, and I think we're doing a lot of the presentation, but there's also a lot of other DSS team here, and Colleen as well, excuse me, that I see on the call. So, and I welcome all of them to add their expertise into this slide deck. So I think I'm first turning it over to Lauren to do the MFP presentation.
Thanks, Bill. Good morning, everyone. I am Lauren Carabetta, and I am the program manager responsible for the Money Follows the Person program. As Bill mentioned, we have quite a few topics that we're going to be updating you on today, and we'll be starting off with our Money Follows the Person update. So as many of you know, Money Follows the Person, it is a program that helps individuals who are in institutional settings transition to the community with different supports and services. We provide information and options to individuals, and we support individuals' choices. As I go through the next few slides, I'll be sharing some updates on our benchmarks. And I would just like you to please keep in mind that the data that you're going to see is based on the latest data available at the end of the quarter, June 30th of 2023. Our first benchmark is related to the number of transitions from institutions to the community. The total number of transitions from the beginning of the program through June 30th of 2023 is 7,697. So we really do continue to exceed this benchmark and looking forward to helping more individuals transition to the community. Our second benchmark is to increase dollars to home and community-based services. You can see the line graph indicates that in 2022, 58% of Connecticut's Medicaid long-term care expenditures were spent on home and community care, compared to the 42% spent on institutional care. The 2022 decrease in institutional spend could possibly be a result of individuals opting out of institutional settings due to the pandemic and a change in Medicaid program focus towards community supportive services. Our partners at the Yukon Center on Aging actually submitted a research letter to the Journal of the American Medical Directors Association, which included their finding that positive cases of COVID-19 and COVID-19 related deaths were substantially higher in institutional settings than in community-based settings with home and community-based services in place. It's also possible that more individuals were choosing to return to the community instead of an institution following a hospitalization. And these are just a few hypotheses, but further research into the data will be needed. And there has been a trend in the shift of institutional to community care pretty consistently since 2017. And we're really interested to see the 2023 trends as the public health emergency unwinds. Our third benchmark is to increase hospital discharges to the community rather than to institutions. The line graph indicates that 62% of hospital discharges were to home and community care, with 38% of discharges to skilled nursing facilities. And as you can see, this has been pretty consistent in the past few years. Our fourth benchmark is to increase the probability of returning to the community during the 6 months following a nursing home admission. The bar graph here shows that 35% of people admitted to a nursing facility returned to the community within 6 months. We continue to work on this benchmark and look for ways that we can make a bigger impact. Our fifth benchmark is to increase the percentage of long-term care participants living in the community compared to an institution. The line graph here depicts that 69% of people receiving long-term services and supports are receiving those services in the community. And as MFP continues to provide options to individuals, we are expecting to see this number change. And overall, the trend has been rather consistent towards community living. People who participate in our program report on their happiness with the way that they live their lives after they transition to the community. More than 80% of people report being happy with the way they live their lives after 12 months in the community. And this measure really highlights the impact of the work that we do. And we definitely have more work to do to help people feel more supported in the community. And through our program, we offer people choices about how and where they receive their care, and that directly impacts their quality of life. Currently, we are seeing a few prevalent challenges to transition. A couple of examples of these challenges are related to locating affordable, accessible housing, and also locating individuals who are part of the workforce. As you all know, we are definitely experiencing a workforce challenge in the home and community-based services arena. We continue to review the data that we collect, and we are working hard in our project teams to identify different strategies to reduce these barriers and increase transitions. We've also been engaging in training programs for all of our staff and working on ways to identify how we can improve our processes and ultimately our members' experiences. And many of the initiatives and programs that you're going to hear about today were identified to address some gaps that we uncovered through our work in MFP over the years. And many of these initiatives are helping or will also help address some of the current transition challenges, such as investments into home and community-based workforce. And we're really excited to see how these new initiatives are going to impact our MFP members. And we're looking forward to making a greater impact and better supporting individuals and their choices. And next, I will hand it over to Carrie.
Good morning, everyone. My name is Carrie Fellick. I am a program manager with the Department of Social Services Community Options. I will be going through some slides today, first starting on Community First Choice, and we'll run through CHESS, and then we'll end or move into ARPA, American Rescue Plan Act. So Community First Choice, just as a quick reminder, it's a Medicaid entitlement for people who are at institutional level of care that gives them the choice or an option of receiving personal care attendant services in the community, what we call PCA services. So Lauren, if you could hit the next slide, please. This is just an overall picture of how many people are active or receiving Community First Choice services right now. We do have it broken down by people who are accessing CFC along with a waiver, a 1915C waiver, and people who are just accessing Community First Choice through the general state plan entitlement. So you could see we have over 6,000 people accessing Community First Choice right now. That's the column or the chart on the left. And then over on the chart on the right, we do have it broken down by waiver type. So you could see ABI 1, acquired brain injury 1, acquired brain injury 2, autism waiver, Connecticut home care program for elders category 3, personal care assistance waiver, and DDS waivers. We grouped all of them together there. So that's the breakdown of people receiving Community First Choice services right now. Next slide, please, Lauren. Just some next steps. We're continuing to work on a new PCA Employment Network website. Really, it's based on person-centered principles and equity. We're looking to help employers match with employees. This has been something that has been an incredibly important topic at our CFC council members, just for DSS overall. We're partnering with DDS, Developmental Services. So something we're looking forward to continuing is how we could help our Community First Choice members really connect with PCAs or employees in the community. Some changes that we're still working through, but happy to announce we are in, I believe, the final stages of working on a new fiscal intermediary contract for 3 state agencies, and DSS does use the FI services for Community First Choice. And then more information to come in the future is adding agency-based personal care attendants or PCAs to the Community First Choice program. So hopefully we'll have more information in that area and some next steps, but just wanted to really highlight some big picture items and areas that we're working on right now. Next slide, please, Lauren. Sorry, I have a little bit of a cold, so I apologize for the interruptions. I'm going to talk about CHESS. This is Connecticut's Housing Engagement and Support Services Program. It's a service for people who are receiving Medicaid, who are experiencing homelessness and trying to access homelessness services. Next slide, please, Lauren. And CHESS looks to combine Medicaid services, supportive housing benefits, and non-Medicaid housing subsidies to really help people in the community secure housing and then find housing and maintain that housing benefit, plus those other services. We really hope to achieve housing stability, improved health and community integration, and life satisfaction. To date, we could proudly say we've helped 214 people secure housing through the CHESS program. Just some quick updates on where we are. We did exhaust a lot of the state. We exhausted our state-funded RAPs, our rental assistance programs. So from that point, we've just been reevaluating the program to really ensure that it's serving people that are experiencing homelessness by coordinating Medicaid services with non-Medicaid housing subsidies. So I know this is a big topic in the interest of a lot of departments. We partner with DMIS, Department of Mental Health and Addiction Services. So it's something that we're just really doing a deep dive into to really make sure that we could hopefully serve more people, and how could we really aim to continue services, supportive housing services. Next slide, please, Lauren. This is just a reminder. The requirements for CHESS, they are pretty extensive. So there's financial requirements. So having active Husky A, C, or D, be 18 years or older. And then there's some other needs-based criteria we sort of group together as functional needs. So a behavioral health diagnosis, and then those 3 bullets below, experiencing homelessness or at risk of homelessness, have a modified Carlson Comorbidity Index score of 4 or more. What that really says is how sick someone's likely to be in the future, and then have at least 2 critical needs. So those are all the requirements. So it's a very person-centered process. So when we receive applications, a person must meet all of those CHESS requirements, just not 1 or 2. The services, the Medicaid services, so just want to emphasize there, these are the 4 Medicaid services: care planning, development, and monitoring, pre-tenancy supports, tenancy sustaining supports, and non-medical transportation. What I want to say about pre-tenancy and tenancy sustaining supports are that there's a lot of activities that are grouped within those services that our providers could work on. But overall, those are the Medicaid services, and just a background slide on CHESS. Next slide, please, Lauren. I'm going to jump into the American Rescue Plan Act, ARP 9817, which really focuses to strengthen, expand, and enhance Medicaid services, home and community-based services for Medicaid members in the state of Connecticut. It's an extensive plan, a very robust plan. I have highlighted here a few areas that we're going to get into. The project leads are on the call with me, so I just really want to point out quickly to recognize the staff here. Colleen Hudson, will be hearing from her a little bit, to cover value-based payments and racial health equity. Greg Bennett, who's covering assistive technology. Angelique Pearson, who's covering innovative services and supports model. Mike Pecorelli, who's covering universal assessment. And then Hye-Young Kim, who is covering supports at home option, as well as our 2 evidence-based models, COPE and Capable. And they're on the call, and like Bill said earlier, happy to have their expertise and their involvement in these projects. So we will jump into the American Rescue Plan Act. We're going to go through each of these areas focused here, and then towards the end of the presentation, we have a summary slide of where we are and some next steps. So Laura, next slide, please, and I will turn it over to Colleen Hudson.
Hi, good morning, everyone. My name is Colleen Hudson. I'm a public assistance consultant with the MFP unit, and I'll be giving some information on the Health Information Exchange and value-based payments. Next slide, please, Lauren. To improve Medicaid health client health outcomes, the Connecticut Home and Community-Based Services American Rescue Plan Act program aims to create and sustain a value-based fee-for-service delivery model by providing whole person care through incentive payments to HCBS providers based on clearly defined outcomes. So we are expecting providers to reach certain benchmarks that include two primary components. First, entering into data sharing agreements with our Health Information Exchange System, also known as CONI, and participating in our learning collaboratives, which as well as racial equity trainings that we are offering. CONI's purpose is to create a platform to support healthcare delivery, to support healthcare delivery, quality, safety, and value for Connecticut healthcare organizations, providers, and residents. At the bottom of this slide, our website has more information on the value-based payments, and the next section that I'm going to be talking about, which is our web-based training modules that we have available. Next slide, please, Lauren. So again, I'm the lead on the Trauma-Informed Care Racial Equity Lens Initiative. And this initiative is in place to support our goal of providing quality healthcare to all of our members. We want to ensure that the delivery of home and community-based services is done in a way that is culturally sensitive. So we have designed a series of web-based training modules that are located on our website. And we've designed these web-based training modules to enable HCBS providers to better understand certain challenges and barriers that certain challenges and barriers that are here and prevent quality delivery of healthcare to all of our residents. So the web-based training modules, we have certain focus areas that they will address. And it's not on the slide, but the web-based training modules will address right now 4 focus areas. First is health literacy and self-management, cultural humility, implicit bias, and racial microaggressions. We do have a new module that has been developed and will be available next year. And the topic of that module would be social identity theory. So in addition to the training modules that I just mentioned, we have learning collaboratives, targeted learning collaboratives for agency racial justice champions. So after participating and completing the web-based training modules, we are asking agencies to name a racial justice champion. And this staff person will be attending our learning collaboratives, which the purpose of the learning collaboratives, they're different than the web-based training modules in that the learning collaboratives are not another training. Basically, the collaboratives provide additional racial health equity information and resources that supports the information that the providers have learned from the web-based training modules. It's basically a platform where the racial justice champions, we all get together, we discuss diversity, equity, and inclusion principles further. Excuse me, I'm sorry. Okay, so with that in place, it is our goal with these learning collaboratives to have the racial justice champions go back to their agencies and help to institute changes within their agencies that will help us to achieve our goal of providing quality health care for all of our members. We also offer, right now, we have monthly diversity, equity, inclusion newsletters that are currently being offered only to our MFP unit staff. However, it is our intention to have these newsletters included on a more public platform, the DSS MyPlace CT and Employment Network websites. It is also our intention to have a resource library also available on a public platform where providers can go at any time and access additional resources and information on all of the focus areas that we discussed during our, that we've highlighted in our web-based training modules and have discussed in our learning collaboratives. And with that being said, I'm going to turn it over to Carrie for additional information.
Thanks, Colleen. So we're going to move into assistive technology. So one of the areas in ARP 9817 that we're currently working on. Next slide, please, Lauren. And it's actually sort of broken down into a few areas. The first that you see on this slide right here is integrating smart home technology into subsidized housing. This is something that it's been a little bit of a slow move forward, but something we're still hoping to do and to look at. And this calls for a request for application. So RFAs that would be released to the program or to the public. And the program will offer grants to help integrate smart home technology into subsidized housing into Connecticut. Some examples of smart home technology include home monitoring, use of smartphones, tablets, computers, technology for controls that automate appliances. So how can we leverage technology to help increase independence in homes for members' quality of life and to really allow people to age in place and stay in the community? So something we are making progress on, but otherwise still looking to move forward with this process. Next slide, please, Lauren. The other area that we are hoping to expand the use and access to assistive technology relates to care planning and home and community-based services care plans, person-centered care plans for members. And what we really want to make sure is that we're committed to prioritizing and expand the use and access of AT, assistive technology, for our Medicaid members. Some of those areas include integration of assessment tools to integrate technology on a wider scale into HCBS care plans. So those are the people in the community receiving services. Through this process, we've been consulting with a lot of other states over the last few months, last year, to understand how other states have done this and how we can make sure we go forward. We have a really engaged subcommittee that are involved in giving great feedback, and how we can also partner with that subsidized housing that I had previously mentioned, and then connection to community hubs, which is a new provider type under another area of ARP that I'll get to in a little bit. But really for this other piece, how can we make sure that our staff understand assistive technology? How can we make sure that our staff understand assistive technology to be able to explain it and assist members in coordinating those services so people can really have access to that AT. Next slide, please, Lauren. The next area of ARP, we bucket it, or we call it innovative services and supports models. There's a few different activities. I'm going to really focus on one called remote supports, and this is the connection to AT that I had just mentioned. Next slide, please, Lauren. So I believe we've mentioned remote supports last year as well. It's a new service option that we're really hoping to engage members through technology. So by having that expanded assistive technology, the use and access to AT, it will help us expand remote supports. What we plan to do with remote supports, like I mentioned, it's a new program we're hoping to offer to our members who are accessing Connecticut Home Care Program for Elders, CHCPE, PCA waiver, ABI 1 and 2, and autism waiver, as well as our supports at home option show members, which I'll talk about in a little bit, and our community first choice members who meet those functional requirements. But with remote supports, what we're hoping to do is create a new provider type, what we're calling a community hub. So really valuing localities and communities and having the support of a local community to help support members, and just placing that importance to that we know that our members value in being engaged in their community, and expanding that through this remote supports provider community hub. And this would look to, integrate assistive technology into that. And some of those services include 24-hour remote supports, which is outlined in the member's care plan, connection with a 24-hour on-call nurse, and some other areas include scheduled on-demand interactions with somebody at a remote location, which is that community hub, or that community hub provider responding to an alert from one of those devices. So I previously mentioned some monitoring or smart technology that these providers would then, as outlined in the plan, and then as a part of provider enrollment, respond to some of these alerts. So this is still in development. There's a lot of steps we're working on. We have regular meetings. We have great subcommittee meetings as well, learning from other state agencies who do this model and how we could really embed this into these different programs. We're hoping to have more information on a timeline and when we could get remote supports and start that provider enrollment for community hubs. But something we're actually really looking forward to, as this program would allow members to, again, remain in their community home, wherever they access that, increase independence, support choice of where a person wants to receive services, and then leveraging that technology piece. In addition, there's also a value for informal caregivers who might be out of state or out of town, who'd really like to be involved with their family member or loved one's care, and how we could help that through technology, how we can keep informal caregivers involved through assistive technology as well through the remote supports program. Next slide, please, Lauren. Some other activities we're working on under innovative services and supports models, Healthy Food Initiative. Just want to highlight some work groups and meetings that our staff have been involved with, just referencing that there. How we could get healthy, culturally appropriate meals delivered to members with the intent to treat symptoms of diet or nutrition related illnesses or chronic diseases. And the last piece, and this is fairly new as well for us, how can we support the PACE program, which is programs of all-inclusive care for the elderly, PACE. So a lot going on under innovative services and supports model, a lot of meetings that are taking place and hoping to have more information and timelines and where we are and when we'll be able to start moving forward with some of these. Next slide, please, Lauren. I'm actually going to turn it over back to Lauren for universal assessment.
Thanks, Carrie. As Carrie mentioned, our next topic is the universal assessment. So this is another one of the initiatives that we're working on related to the American Rescue Plan. We are working on updating the universal assessment tool to both expand and improve the tool. And as Carrie mentioned, Michael Pecorelli, a public assistance consultant on our team, has really been doing a lot and leading this work for us. So as many of you are aware, the universal assessment tool was established as part of our overall rebalancing strategy. The tool is utilized by multiple programs and waivers to determine an individual's strengths and needs. The UA also utilizes an algorithm to determine level of need and level of care. In terms of expansion, we are working to expand the utilization of the UA to participants receiving services from the Department of Developmental Services. Test cases are currently in the quality control phase to verify and ensure that there's accuracy with the DDS algorithm. In terms of improvement, we have conducted a comprehensive review of the UA and identified opportunities for improvements. We have held focus groups with many of our key stakeholders in order to identify areas to increase efficiency and accuracy throughout the assessment. We also have identified opportunities to rework and reorder the UA in order to improve the overall flow of the items throughout the assessment and to collect information in the most logical way as possible. We also are looking to update the UA to Interi's more recent version, which would be version 10. We are going to be finalizing our quality control review and working on a request for quote to identify a vendor to make improvements. And we're also working on creating and submitting an advanced planning document, which will be submitted to CMS, the Center for Medicare and Medicaid Services, in the near future. And I will be handing it back over to Carrie for some additional updates.
Thanks, Lauren. I'm going to jump into supports at home option show. I mentioned it earlier in one of the slides. This is a new program that we're hoping to offer to members. Next slide, please, Lauren. And what we're looking to do is actually, we're calling it expansion of the Medicare Savings Program for people receiving Medicare Savings Program services through DSS. It's really a light package of home and community-based services through this benefit, aiming to prevent unnecessary institutionalization decrease reliance on Medicaid and paid supports, and reduce signs of depression and increase quality of life. Through this, we're hoping to implement a caregiver assessment, dementia supports, care coordination, small respite budget or services, and training for unpaid caregivers. There is a functional requirement you can see here, needing at least assistance with 1 or 2 critical needs and active on the Medicare Savings Program. The show services, I mentioned it's very light. This is what we're looking to add under this expanded benefit for MSP members: case management, I'm going to skip capable for now, respite care, environmental adaptations, which we also call home modifications or a small home modification budget, use of assistive technology. So just connecting it back to that other major ARPA area, why expansion, access, use of assistive technology is really critical, because it's something that we see throughout all the ARPA programs, and how can we really benefit that, as it's also the way of the future. 2 evidence-based models I'm going to jump into very soon. The first one is informal caregiver supports, which we're calling COPE, care of older persons with dementia in their environment. A sister model to that is confident caregiver. The difference is there's no, it's for people who don't have a dementia diagnosis. So that's an important piece to make note there. And the other evidence-based model is capable. I'm going to hope I get this right. Community aging in place, advancing a better living for elders. That's a mouthful. It's probably been a year since I was able to say that. But a second evidence-based model that we're hoping to implement and add. So really, the summary of show is an expanded light HCBS package for people receiving Medicare Savings Program. And of course, just running through that same process. We're hoping to have a more updated timeline, looking to maybe start this sometime this winter. So more information to come on that. Next slide, please, Lauren. I did mention those 2 evidence-based models. I'm going to talk about these briefly, and there's some additional information linked in this presentation as well. Next slide, please, Lauren. The first one, care of persons with dementia in their environment, COPE, and confident caregiver, the sister program for that, minus the dementia diagnosis. It's an evidence-based program designed to enhance the well-being and quality of life for both the member living with dementia and their caregiver. So really the target and the intention of this evidence-based program is to support our members and their informal caregivers as well. You can see here the expected outcomes, first for the members: functional independence, activity engagement, quality of life, improved quality of life, prevention or alleviation of neuropsychiatric symptoms related to their diagnosis. And then there's actually outcomes as well for caregivers. So that's perceived well-being and confidence in using activities to manage dementia symptoms. So there's really, it's a 2-fold benefit for COPE. This link here, more information, it's actually administered through Drexel University and Thomas Jefferson Hospital. We're partnering, following that same model, a very defined set and prescribed program with a set number of visits and team-based approach, using RN and OT, registered nurse and occupational therapist services. The second evidence-based model we're adding is capable, community aging in place, advancing better living in elders. It's a person-centered approach that uses a team model consisting of a nurse, an occupational therapist, and a handy worker to address home environmental modifications or adaptations. And this uses the strengths of older adults themselves to improve safety and independence. Again, we have projected outcomes: improving the independence, safety, and health of our members, lowers healthcare costs. Right here it says reduces hospitalizations or delays for nursing home admissions, enhances motivation and self-efficacy, and reduces health disparities, as well as reducing symptoms of depression. We are partnering, so it's administered through Johns Hopkins School of Nursing. Again, the link to Capable, if you're interested in more information, is linked right there at the bottom. We're looking to still run through this, some design, I don't want to say challenges or hurdles, but some things that we're just trying to work through, and updating this timeline of when we could be able to launch this, which we're hoping sometime this winter, to be able to help members access COPE and Capable services, and then start those in their service plans or care plans. Next slide, please, Lauren. This slide is a summary of all the ARPA areas that we talked about today with a very brief description of those areas. And in the column on the right, there's a next step. So some activities that we're working on. So there's just a lot of internal design and meetings and things that we need to work out and figure out. And really, how do we take something and embed it in the Medicaid program? So those are just, I don't want to say it's a challenge, it's just part of the process of new design. But you could see for HIE and value-based payments, continue to partner with the National Committee for Quality Assurance, which is NCQA. We're partnering with them right now to develop person-centered goals for outcome-based measures for value-based payments. Continue to partner with Yale's Center for Outcomes Research and Evaluation, which is CORE, to develop measures to decrease health disparities. Continue with benchmark period learning collaboratives, which we're currently in one right now. And that also includes the racial health equity and person-centered principle training, the learning collaboratives that providers are attending. Assistive technology, one of the next steps, release the RFA for smart home technology, further develop assistive technology assessment and process with our access agencies. Innovative supports and services, really I'm focused here on remote supports, continue to work through design details and provider enrollment for those community hub providers. Universal assessment, Lauren, and already covered this on the slide, but just that same information here. Supports at home option, we want to finalize enrolled providers, finalize the start date of new services. For COPE, start provider training and enrollment, and the same is true for Capable, as both COPE and Capable require certification or licensures from those universities or the main programs, which would be Drexel and Johns Hopkins. So we have a lot to do, a very robust agenda for ARPA, really hoping to, like I mentioned earlier, strengthen, enhance, and expand home community-based services for members. And over the next few weeks, we're meeting internally to really get a good handle on where we are, timelines, and put some more formalized and final timelines to some of these activities. And happy to share that and looking forward to being able to move forward with a lot of these for our Connecticut residents. And I'll turn it back to Lauren and Bill.
Happy to take questions.
I actually have one, Bill. I don't see if anybody else does. I thank you so much for that excellent presentation. It was a lot of information, and I'm guessing that as members go through the slides and it sinks in, that some more questions will come in. I just wanted to circle back for a minute to the concept of the community hub. And I was wondering, Carrie, would you be able to just provide some detail as to what types of entities would be serving as these community hubs? And I guess I'm still trying to parse out where they are, who they are, and exactly what is the concrete service they provide to the person who would be seeking supports from them.
Yeah. Those are great questions, Melissa. I'm just going to pull up in my notes quickly, which I probably should have had open at the start, but I can answer some of that information. So let me see. So first, let me see. We are looking, so what this does is we're creating a new provider type, but there will be qualifications for those providers who intend to be credentialed or enrolled to be a community hub or considered a community hub. Right now we're looking at adult daycare centers. I had mentioned an RFA for smart home technology for subsidized housing. Just, is that an expanded provider under community hubs and that connection there? So that would be another provider who would potentially move forward with enrollment to be a community hub. A new provider type who's just interested in enrolling to be a community hub provider. And then I know Angelique Pearson's on the call and I'm drawing a blank on this. So Angie, I'm just going to phone a friend. Well, I'm missing one more. I think it's a home health agency, but I can't recall.
Good morning. Good morning. Angelique Pearson, at the State Department of Social Services. The other entities that are eligible to become community hubs would be homemaking and companion agencies, congregate housing sites and other subsidized housing sites, senior centers and municipalities, in addition to the adult day centers.
Great.
Thank you, Angie. I appreciate that. And then what we are asking of those providers, so we're right now, some of the design meetings we're working on are defining qualifications and expectations and what those providers are expected to do once they enroll as a community hub and how they meet the qualifications. But ultimately, this just goes back to the services that are embedded or will be embedded in remote supports. This includes the monitoring. So we had mentioned that 24 access support to the access of a community hub. So that remote monitoring piece of it. So a community hub must be able to provide that. We also have what we're calling a remote live, which is with planned check-ins, scheduled planned check-ins, which is specific to a member's care plan and their service needs. So a community hub must be able to provide that as well as accommodate unplanned, unscheduled check-ins that are maybe they could also be from initiated from the member. So I forgot if we touched base earlier today. I know you were supposed to call me at noon to prompt me to eat lunch. I forgot if we did that, but I'm going to call you later. And can you confirm community hub if I did that? So those unplanned, unscheduled check-ins with a community hub initiated by the member. And then responding to an alert. And the last component is, and I didn't mention this, but this is a detail in this is some members may identify the community hub in their emergency backup plan. So in some instances, a person might name a family member or member as an emergency backup. Some people we know don't have access to that additional support and have the ability to name a community hub as that emergency backup person. So they would also have to be able to provide with that in PCA or in-person PCA services in the event that there is a call or need for an emergency backup through this community hub. With that, it also being able to support the assistive technology. So a lot of this is using assistive technology, using these devices and what that looks like. So all of these details, Melissa, which I really appreciate the question. Those are things that we're trying to work through and put down on paper and make sure that everything we've identified and that we're expecting from community hubs is documented and we could see it. So we're still working through that.
Great. Thanks so much. I appreciate it, Carrie. Anybody else have any questions for the DSS team? Oh, Michael.
Thank you. Thank you very much for the presentation. I appreciate the opportunity to hear what's going on. When you do your RFA for assisted technology in supportive or affordable housing, certainly please be sure to reach out to the Department of Housing. We will be more than happy to distribute it to the various projects that are either pending development or under development, see if we can help you find a match and get things moving.
Thanks, Mike. Appreciate that. Will do.
Okay, anybody else before we move on? Okay, thanks so much, DSS team. As always, that was excellent. A lot of great information. And so we will be in touch for future updates as you move along. Sounds like you have a lot of moving parts right now. So with that, now that we have some more members who have joined, I think we're going to circle back to the top of the agenda before we get into long-term care member updates and advisory council comments. I just want to go back up to the top and take our vote on the approval of the July 11th, 2023 meeting minutes. Did everybody get the minutes prior to the meeting and have a chance to look at them? Great. So with that, would someone like to make a motion to approve the minutes from July 11th?
So moved. This is Amy Porter.
Thanks, Commissioner. Second,
Second, Mike Santoro, Department of Housing.
thank you, Mike. All in favor?
Aye.
Any abstentions?
Margie, I was absent. Thank you.
Okay. So with that, I believe everybody else voted yes. So with the exception of Margie's abstention, the minutes are adopted. And now we can get back into the normal order of our agenda, which is with member updates and announcements. Do any of the members have updates or announcements that they would like to make this month? Margie.
Thanks, Melissa. So I just wanted to share an update from the Department of Aging and Disability Services State Unit on Aging, and I'm Margie Geronda Marquette. So our department submitted an application to participate in a multi-sector plan for aging national learning collaborative through the Center for Healthcare Strategies. And we were accepted into the collaborative as one of 10 states through a year-long process to get started with a multi-sector plan for aging. It's also called an MPA. Some of you may have heard it as a master plan on aging. So to just give you just a little bit of background on this, so as our population gets older, we all recognize the need to conduct these planning efforts to really ensure that the needs of older adults, persons with disabilities, and caregivers are met over the next decade. And there are a lot of plans out there. We have the long-term care plan, we have our state plan on aging, and the MPA planning efforts are much broader in scope than existing plans. And an MPA is a long-term plan that could be 10 years or even more. And it's a roadmap that helps states transform policy, infrastructure, and service coordination for rapidly aging populations. So an MPA is a cross-sector planning effort that engages a range of state departments. So we envision that we'd include all of the state departments here on the Long-Term Care Planning Committee and other departments as well. And it really identifies and aligns common goals across agencies and stakeholders and really elevates aging and disability initiatives. So just to share who our Connecticut team is, including our department, there's also a representative from the Connecticut Age Well Collaborative who helps spearhead this, along with DSS, and Carrie Billick is one of our members. OPM, the Commission on Women, Children, Seniors, Equity and Opportunity, and also the Connecticut Council for Developmental Disabilities. So I know as we go through this process and as we're learning, we're going to gather some more information from all of you. I'm happy to provide updates at future meetings to share our progress on this as we learn more about how an MPA would really benefit Connecticut. And I don't know if the commissioner had anything to add there.
You did a great job. Thank you.
Thanks. Thanks, Melissa.
Thanks. Anyone have any questions for Margie? Okay, do we have any other agency updates? Thanks, Margie. We look forward to hearing more about that initiative as it progresses. No other agency updates? In that case, I will move to, do we have anyone present from the Long-Term Care Advisory Council who would like to make some comments?
Yes.
Hi, Michael.
Hello. Hello. Good morning, everyone. Thank you all for a great meeting, great presentation. And my announcement for today is we are looking to have our next meeting of the Long-Term Care Advisory Council coming up on September 28th at noon. We're still finalizing our agenda, but we'll be sending that out shortly. And we're looking forward to have folks from the Office of the Long-Term Care Ombudsman, the Alzheimer's Association, and the State Unit on Aging to join us and to share some updates. Thank you all very much.
Thanks so much. Appreciate it, Michael. So we're going to move into other business at this time. Do any members of the Long-Term Care Planning Committee have any other business they would like to raise before we move to public comment? No? Okay. Seeing none, we'll move on to public comment. And I see Andre Brell, you have your hand up.
Yes, thank you very much. Good morning. Nice to see you all. I represent. I'm a member of advisory board, and I cannot stop myself to comment and say thank you to this DSS presentation, because the Adult Day Association was mentioned not once, not twice, several times. It is because we are becoming a part of the planning and future initiatives. Some initiatives that you mentioned, they already exist, like value-based payments. We're part of this. We are benefiting from them. We get some needed money, rate increases through this program. We're looking forward for the CANI. It could be excellent exchange for us, additional tool to provide great services for our customers. The community hubs, I think it's a natural organic move for Adult Day centers, because we're already doing this. And again, I have to praise and thank you, DSS, Department of Social Services, because it's just been approved wellness call or remote services that were implemented during the COVID, and it was a temporary measure, life-saving measure for our customers and for the providers. But now it's becoming permanent, and I have to say personal thank you to Amy Dumont and her team, that you're working so hard to make it sure that it exists. And I think those wellness calls or remote services, it would be very nicely forwarded or promoted towards these community hubs. We're already doing this. We have expertise, and we can continue to work with DSS on implementation of this. And also other initiatives like Capable and PACE. Again, it's a very, very close connected to our services that we already provide. That's why we see a very, very bright future to work together with Department of Social Services and DMAS and DDS, of course. Thank you so much for what you're doing, and I'm looking forward for the next year. It's going to be great. Thank you.
Thanks so much. Okay, before we wrap up, any other public comment? Okay, so with that, our next meeting is scheduled for Tuesday, December 12th, again from 10 to noon. We're going to continue based upon the consensus feedback from planning committee members. We'll continue to meet virtually for now. So we will see all of you on December 12th. Thanks so much. And may I have a motion to adjourn?
Motion to adjourn.
Thank you, Michael. Second? Nobody wants to leave. We're just going to hang out. Okay. Commissioner Porter, thank you. Second. And with that, meeting adjourned at 10:05. Thanks so much, everyone. Have a great rest of the week.
Thank you.
Thank
Melissa,
you.
Thanks all.
Thank you.